Dr. Anne-Marie Charpentier, radio-oncologue at the CHUM, professor at Université de Montréal. Welcome them, applaud them if you applaud them. Dr. Erica Patoski, oncologist, professor at Université de Montréal, chief of service at the CHUM. Dr. Saima Hassan, professor, surgeon, and oncologist at the University of Montreal, and one that does not need any more presentation, Marianne Côté. Hello, all. Thank you for being with us today. Surgery has always been the preferred treatment for breast cancer with chemotherapy. But within the last few years, new technologies, new ways of doing have appeared. Dr. Petowski, today are prescribed treatments that affect the whole body, just like chemotherapy. Before surgery, thank you for this invite. I am very pleased to be amongst you. Historically, surgery would be the prime solution. We knew that the relapse levels were very high, and so we would try to join it with immunotherapy, hormonal therapy, targeted therapies, and then historically, we had data, so we'd have surgery and then systemic treatment. Ever since then, or in the last 20 years, and more today, we eliminate chemotherapy, and we try to eliminate systemic surgeries if we're able to do so. So the first thing we do when we see a cancer patient is we try to see what is the first decision. Can we provide or dispense a systemic treatment before? And if not, we go through the surgery, and then we see the pathological report to then take a decision. As surgeon, we also think that it's easier. The margins are larger. We can even do a partial mastectomy instead of proceeding to a complete one. Sometimes we can see a 35-year-old woman with a very negative, huge mass, and then we'll give you immunochemotherapy before to let it melt, and then after that we'll give them a partial mastectomy, and it's perfect. And so it's incredible. When it comes to the lymph nodes, we realize that we don't have to take all the lymph nodes out before surgery. But we also know that the treatment works. We see the pathology report and we have an idea on whether or not it functioned well. If not, it gives us the opportunity to dispense other treatments. And if it works very well, and we'll make a little dance and cross our fingers that things go well, we might be successful and not have to give more treatment. Surgery is very easy. Who can benefit? Which patients can benefit of the treatment before surgery? As I said to the patient before, you have to know that you have to dispense a treatment before. In order to give this treatment, we have to make sure that chemotherapy is necessary. And sometimes we don't know, especially when the hormonal therapies are FLASH-R2 negative, we don't know if it requires chemotherapy. And so we'd like to go to the surgery before, and then we'll see with the pathology report. But usually all triple negative mass, HER2 positives will be in young patients who, for example, have negative lymph nodes will need chemotherapy after. And so we feel very comfortable giving this treatment prior to the surgery. Dr. Hassan, are there any tests that can help determine which people can benefit from chemotherapy, having this breast cancer with negative cells? Now, ever since 2010, 2011, we've been using a genetical test called the Oncotype, or precisely a recurrence score test, in order to find out with patient that has an immunodependent breast cancer needs chemotherapy and who does not need a chemotherapy. This test is a gene test which tests or analyzes the expression of different genes and generates a score. That score goes from 0 to 100, and this score is used to predict the relapse risk. This test has evolved. At first, we would use it in a context where the lymph nodes were negative. But recently, within the last few years, even the patients who have positive lymph nodes, one to three, will have this test conducted on them to see whether or not they need chemotherapy. This changes the way that we practice things on patients that are immunodependent and on those who have positive lymph nodes and who don't need chemotherapy, or those, because before we used to all start with chemo as soon as we had cancer. I want to start something, just a question. Can you speak to us of the results? Like 1 to 100. Can you speak to us about this scale? It's a little bit complex to resume, but at the same time, I will try to speak in a less complex terms. If we analyze the negative lymph node context, we use a threshold of 26. So if the score is high, then we need chemotherapy. If our score is lower than 26, in a context of patients that are more than 50, where we are completely sure that we don't need chemotherapy, we're fine. But if a score is between 18 and 26, we esteem that this is a gray zone. Within this gray zone, we'll have discussions with our patient, but we will use other clinical factor to know what is the true risk in the context of positive lymph nodes. We do not need chemotherapy in a context when patients are going through menopause. But in the premenopause state, the value of this test has not been proven in clinical tests. Yet there are clinical tests that will come in order to answer to this question. In order to perfect my culture, the test that we hear with a lot with the doctor, is it done before surgery or after surgery? It has been approved for after surgery. After surgery, we would know what is the context for lymph nodes. Are they implicated or not? Before surgery, there are studies that have demonstrated that the biopsy results are reliable. Nonetheless, it is not approved by the government in this precise context. But it's a situation, it's a case-by-case situations, and each center treats the information differently. After surgery, we're going to have standard care, but that is the way that we usually practice. But research is ongoing to see whether or not we could proceed before. Perfect. Dr. Pratoske, you said that the neoadjuvant surgery treatment before surgery will alleviate certain issues. But how do we ensure that there are no cancerous cells left in the lymph nodes? Usually, what we do is that the patient will have the adjuvant treatment, and then the radiologists who work, the MRI specialists, are really good. They're able to target the lymph nodes which had metastasis. And so there's an initial marker put on the specific lymph node, and then we want to make sure that they reduce in size, and the radiologist will come back and try to find this positive lymph nodes. And then they'll place a radioactive pearl. There's other technologies, Maxi, in order to retrieve this lymph node. And then we will have we'll do another lymph node test. We'll put to sleep the patient, take this lymph node out, and then the radiologist comes in, confirms that we have the proper lymph node, and then when we have it, we're really happy. And then we take out the lymph node. And so the pathologist will call back to tell us, okay, we're good. There are no more cancerous cells in the lymph nodes. And so we'll close we'll sew up the breast and then wake the cancer the patient. But if there's something wrong, we will go back and extract that lymph node. But that step where we validate things with the radiologist it's a beautiful collaboration. The pathologist comes, they insert the pearl, the bead, and then that really, this collaboration ensures us that things are successful. And it's also less invasive, which is really beneficial for the patient. We've talked about surgeries, but we also have the immunotherapy with Dr. Charpentier. There's been a lot of great progress with this therapy. Dr. Charpentier, can you explain to us what is partial accelerated radiotherapy? Who are the candidates eligible for this? Radiotherapy when lymph nodes are not affected and the breast is still in place will come with the radiotherapy to reduce the relapse risk. Traditionally, we would work on the whole mammal gland. Even if the cancer is very small, 4 millimeters, we'll take it out, but if the surgery takes it out, in order to prevent high relapse risk, we wanted to treat the whole breast with our techniques and the machines that we had that were quite limited. Our machines have evolved greatly in the last decade, and what is now possible is to target the specific region in the breast that has been taken care of by the surgery. Because if the cancer has to come back, it'll be precisely near the original zone. And so our devices allow us to work through modulation where we are able to treat the specific portion of the breast that is affected. And that allowed us to reduce, for many patients, the number of seances, a number of chemotherapy therapy seances. So instead of having 15 different seances, different treatment, the treatment has been accelerated and shorter. And so we'll treat the patient on 5 or 6 times. We can do it every day or every 2 days. And so that has reduced the volume of the breast that was treated, but also the number of treatments for patients, which was great. And that also addresses it. This is for early cancers, for cancers who are small in size, who have hormonal positive cells, who are with good margins. For certain in situ cancers, we can apply this radiotherapy, this partial radiotherapy, which is available in majority of centers. Before, in order to treat a part of the gland, we'd have to go with different techniques that were not very available to everybody. So we'll talk about the different therapies where we would put in some different catheter, where we would put in certain devices in order to treat. But now these are standard treatments everywhere.
So we have other parts such as the lungs, the heart, and the lymph nodes. So, if this is the term, but radiotherapy can be fractioned. In the past, we had 15 different treatments, and now, yes, we're in a different context. And now the radiotherapy, for the previous question, this is the accelerated partial radiotherapy, but with the COVID, we also have. Now we have a lot of weeks of treatment, but of course it is not ideal, but for most cancers. And also for prostate and other cancers, we try to look for a formula that is from the biology, and from the time management we try to do in a more condensed way, which is good in order to fraction this. We have 2 sessions in a day, but at the end it's going to be the same, is going to have the same number of sessions. Of course, it is safe and it reduces the number of visits to the hospital and of the mammal gland. And with the part of the breast, we have less sessions. And this change happened during the pandemics and improved the treatment of patients. We have less visits. So if you consider that we don't want to come at 20 times, 20 visits, so we have reduced that also for the treatment, right? So this is the type of cancer that are not very advanced. So we want to do that. If we have some lymph nodes, there it is still 3 weeks of radiotherapy. Yes, of course, we want to have this Canadian study that we have that this is condensed for 5 visits. That it is better than 15 or 20, but of course we try to see if we can even reduce even more for the advanced cancers. Of course, that improves the life of women. For people that come from abroad, sometimes it is better. That is fantastic. Is there any solutions for which we have to propose after the partial surgery? Yes, the answer is probably not. Because we have these patients that have this, the relapse rate is weak. So we are going to work with hormone therapy to reduce the risk of relapse. What happens is that it is we reduce the absolute risk of relapse, and because the risk is weaker, then they had the very good margins in order to operate there. We've seen some studies published recently. If we talk with the relapse rate is similar, but we have 2%. Is it worth having this radiotherapy for patients? The benefits are there, but it's something that we are discussing now with the patients if they are strict. But if they really want to go through this treatment, or they prefer to have the hormone therapy, for the patients that do not prefer to have this therapy, of course, they are going to reduce the relapse rate. Yes, we're going to come back to the presentation, the previous presentation. There are many women that they want to stop the hormone therapy without talking to the doctor. It is important to continue a relationship with this team, the care team, because if we take the hormone therapy, there are some interdependence. It is important to talk to the team, follow-up team. So we also need to talk about the radiotherapy traditionally is given in external clinic outside the hospital, or maybe there is a specific part of the hospital and they come after the surgery. We don't have. We know already if we need more procedures. But of course, if they are accelerator, they have this machine of radiotherapy, and they are going to stop the surgery room. This is specific because we need the blindage in order to protect everyone for this radiotherapy, the radiation. And so they see that if the risk is only weak, instead of waiting for the final pathology results, they say, okay, they can talk about the planning of for the patients who are far away and they don't have the energy to come back. Um, they find it better to do the radiotherapy during the surgery, and then we have all the team with the doctors and the surgeons in order to install the radiotherapy, and we're going to have the blendage, and then we provide the treatment. And of course, that is going to expand the surgery some minutes, but then for most people, they want to do it at this time when the surgery is taking place. We have 45 patients that have benefited from this procedure, and if they are there, they have the new technologies. It could be interesting for patients that don't want to come back. Of course, we also see that the notes are negative for the ganglion. This is also a very good collaboration with the surgeons in order to position the machine within the operating room. And then at the level of the patient, of course, sometimes they see some side effects in the skin of the patients, but we try to protect the skin. Dr. Pataski, you have worked in a research project that is very innovative, and that we used it during the surgery. Could you please talk about that? Yes, it's something that I have been working on for the last 8 years. And it's Lily Leveillé from Quebec, and she's a specialist in mechanic engineering, and they have worked with Field 1, and I was doing this body, and we use the plasma. Plasma is a gas with some reactions being caused with oxygen and also electrons and ions. And we have this applicator that we can use for the plasma and on this on the cavity, and then they kill the cancer cells without killing the good cell, the healthy cells. And this is incredible. I go through Santé Canada and also the scientific committee. The first patient who is going to have this this summer. I think this is fabulous because it's been developed in Quebec. It's something excellent, and the aim is to avoid these treatments, but also to avoid once the operation, we don't need to go back, because this reduces the risks of relapse. And also we've seen for mastectomy and reconstruction, we've seen release the skin, so we don't want to see the scare in the level of this. So in order to keep the skin, don't have to avoid consequences or for the surgery. I'm sorry about that, of course, but it is not the same. It is not going to replace the reconstruction, but we hope to have more news in a year or two. Yes, of course, to see what with the first patient, we want to know that Dr. Berdasky, and this project is funded by the government, but also the foundation. Yes, with the foundation as well. I haven't mentioned that the foundation. It is not I see that the money, but I know that we have. This is the best biomedical project in innovation. We had this. We had. We had this reward. We received this reward. We had Australia. We have Great Britain, but this is Canada. And Canada won this. And thank you so much for the support to the foundation. Thank you. Thanks to the foundation. We also see it's so encouraging to see all these advances with the treatment that are less invasive and has less side effects. We see that research is essential. And of course, and I had this metastatic, so without the research, I wouldn't be here today. Dr. Tesson, can you talk about the new therapies for the breast cancer? This is an aspect that I am really interested in. At the level of the clinic, for the breast cancer, when they lack estrogen and progesterone, in this type of cancer, we need to see a more targeted treatment. With the chemotherapy, we for a long time we've provided the same treatment to different types of cancer, but now the way we treat these triple negative it has evolved. At the level of chemotherapies, we have added a new molecule because this is for about for different events we had added the immunotherapy, and this is the only way how we can show this benefit for immunotherapy when we need to provide this in the neoadjuvant context before the surgery, and then we continue after the surgery. Immunotherapy, the way it works is that it stimulates the immunitary system in a way that it can target the cancer. So in these two ways, this is two ways to attack cancer using the immunitary system of each patient. So the molecule that has been approved is the pembrolizumab, and it showed that it was an important improvement when we melted the tumor during the surgery. At the same time, the results have showed that there is an improvement. Even to 5 years, it was a 9% improvement. So this molecule was approved by Sante Canada, and at the same time by INES last year. And it was one part of this. It was an improvement, of course, and it addresses the patients of breast cancer and then triple negative. This is ERP. ERP. This is a molecule that is targeted. So, without giving too much scientific detail, this is a molecule that it was given orally, and it was only for patients with a mutation on BRCA2. 1 or 2. So this is the first studies showed that this inhibitor, the PERP, can improve the survival. So we started to see benefits in this context. But when we have plus, we see more advantages for the people with neoadjuvant and with this residual illness. That means that chemo and immunotherapy didn't attack the cancer completely. So in this context, we had these benefits on this This is the only molecule that showed this type of improvement in survival for the triple negative patients. The mutation on BRCA1 and 2 is not only for the type of cancer triple negative in this type of for immunodependent, so they could have this benefit of this type of patients. I'm sorry. This is my brain of chemotherapy. Now we're going to summarize what you have mentioned. If I understood really well that, so the inhibitors of PERP, this is the agents in charge of repairing the healthy cells, but we don't want them to repair the cancer cells. So they will repair. So we want them to repair the cancer cells without touching without touching the healthy cells. And then you see the mutation BRCA. We avoid ARDM, and also, and then the cancer cells will be more vulnerable to the treatment. Immunotherapy. Here are some proteins in the control on the normal cells in order to avoid attacking them. But for the patients with the cancer cells, they are going to use this protein in order to disguise and to avoid being attacked by the immunitary system. So they are going to, the inhibitors, they will block the protein in order to continue to allow the immunitary system. I don't know if we have questions from the audience. I think we're there. As I mentioned before, we are going to alternate. We have some questions in Slido, very interesting, and you are interested by this topic. I will start with the Slido, and then I will give the floor to our participant. Why why do we use the permanent tattoo instead of the temporary one once a year, and we don't need the intervention of retreat? Why do we use the permanent tattoo in radiotherapy? It is something historical, but we're conscious of the fact that we should rule that out, because we're trying to work with the patients of breast cancer. If they don't want the tattoo, they should stay that, because historically we don't have this technology link with these machines into 2D. All the patients, they have these images, and of course we need to make sure that we have the timely treatment without using the tattoo. Yes, I understand. I understand that it's something that we're working on with people working in the reconstruction. They've also mentioned that. So we try more and more to rule it out. The permanent tattoo. When we know that there's something that we don't want. Of course, it is not a very it is not nice to have that memory. Of course, we are also sensitive. We're advancing. Okay. Yes. We in my period when I was there, it was difficult, and we used that, and of course, it has evolved. And we needed to, we couldn't wash that out. So the title is already an evolution, of course, but now they're going to evolve even more. The question from the participants? The question is general with everything that we hear here about the innovation for the KEEP, the treatment team. Is it possible to change from location? Sometimes we are not very good, but sometimes we want to see in another place the organization of care is different and the approach is different. So I know that we have the first conference as patients. We can always change of the team or to ask for a second opinion. In the practice, is it very complex to do that? If we go to a process that is really difficult, and the network makes it difficult to change. So I wanted to know that if this is, yes, the factibility of changing of the care team. I think first of all we need to have this appointment. The doctor, if you are not happy with the oncologist, maybe the family doctor can do that, and they have when. We know that in your sense you have this file, you are happy with that. You just want a second opinion, that's fine. But as we can say, okay, no, we do different way in this moment, so you can discuss for the next stages, right? The next steps. And then you have 5 years. We have 50% of patients that only one second opinion, but sometimes it makes you good to talk about a second team of professionals. So it's always good to have an appointment and then ask for a second opinion. This is simple to have this. We can have you can have a referral. You go to the system and you discuss. We also have the second opinion. If we are not sure, the patient is not sure, we see a second doctor, a second surgeon in the oncology. So this is a different approach. So I think it is good to have more information, of course. We have another question here. Can we expect we don't need our surgery after the systemic treatment? Yes, there are some studies that have started to address this question, and I think they will continue. But so far, we don't see the evidence to see that we can leave surgery after the neoadjuvant treatment. And we have this for these studies. We can have also the radiotherapy after the neoadjuvant treatment. So this is also being researched, but we're going to continue following this subject. And there are some studies in the use of the east of Montreal. They say, okay, before the surgery, maybe we can do something different. We can accelerate the treatment. There are some studies showing that they can do it before the surgery, and then we can probably just delay that for the radiotherapy. Last question. Is the survival the same between the partial surgery combined with radiotherapy versus a total mastectomy? This is yes. 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 So when they had these studies at the beginning. It is a lot in Quebec as well, for this Dr. Robidoux, who is exceptional, and he was a pioneer in this idea. They both work together, and they said, okay, this is the Quebecers saying that the partial mastectomy. Now we're going to the SBP and 64, so the figures will increase, but then we have 35 years, and the follow-up is the same. So yes, the risk of local relapse, we see if this is the subtlety of the question. The risk is not there, but the risk is not high, but we cannot say that it is exactly the same to have a mastectomy and to have a partial surgery. And of course, it is the choice of the patient, right? Of their personal health and the preference, the balance. So at the level of the surgery, we prioritize more and more. We prioritize the partial surgery, right? It's only for the precise. But yes, we have this total mastectomy because we see a lot of women with this cancer at the level of the breast. This is the partial. A reasonable choice, but also if we see that there is everywhere in the same, we have with 15 codes, and we have that every week. This is 5 cases a year, and they are always with us, and then with this reconstruction with the people. And I agree with you, and then we are going to make sure that that works. And then I think we are at the end. We're at the end.
Rapidement.
What is, in your opinion, with the counterlateral mastectomy? I unfortunately don't know what she's talking about, but sorry, Dr. Hassan, can you? What is your opinion on counterlateral mastectomy? To answer to this question, there are many factors. First of all, you should evaluate if there is a genetic aspect, or is there a high risk of developing another cancer, and if the criteria are met in order to get a genetic test. Because if the patient has an alteration in terms of some of the cells, that means that the patient may get total benefits from a mastectomy, from a lateral mastectomy. First thing is to see if there's a genetic risk. If there isn't a genetic risk, surgeons won't start from the day to the next to start performing these counterlateral mastectomies. That being said, it's always an important conversation to have with your doctors to see or with the patient to see what are the worries, the anxieties, the fears. But generally, it's really, this is a decision that is taken case by case. It's not something that we will routinely do. We're good? Yeah? Okay, thank you. I thank you immensely for participating, for informing us, for educating us, and that allows us to see that there is a lot of development with benefits for patients, treatments that are less invasive, and it is the research that allows us to to get to our goals. Thank you for participating, and I hand over the mic to you. Thank you, Marie-André.